Hello, this is Charles Denham. I want to welcome you to our High Performer TMIT Testbed webinar series. And our topic today is Learning from Collaboration on Mortality Reviews, the Journey. And my job is to help set the context and address some of the newsworthy issues. But the first thing is to make sure that you have everything set to go on your end as a viewer. So make sure that your computer volume is turned up to the highest that it can be, and I'm on slide 3 for those that have the slides. And if you have a problem with audio, then please click on Participants icon at the top of the page, and then click on Request Phone. It's an icon in the lower left-hand corner of your page. Now, for those of you that don't have the slides, we want to make sure that you go to our website, safetyleaders.org, www.safetyleaders.org. In the upper right-hand corner, upcoming events, if you click on Learning from Collaboration on Mortality Reviews, it'll take you to a landing page that will allow you to then go back and actually watch this in an on-demand fashion and also take advantage of the resources. On slide 7, I just want to draw your attention to our social media addresses. And on slide 8, I'll pause for a moment just to address our purpose statement. So our purpose is that we will measure our success by how we protect and enrich the lives of families, patients, and caregivers, and I think both are really a focus area of our discussion today. And our mission is to help accelerate performance solutions that save lives, save money, and create value in the communities we serve. There's a disclosure statement on slide 9. However, no product, service, or technology will be discussed for which any of our speakers, and including our organization, have any financial interest. And we, on slide 10, Hanan Foley, Dr. Jeanne Huddleston, Dr. Greg Votes, Jennifer Dingman, and I will be with you today. And what we want to do is start off our webinar, as we always do, with the voice of the patients and families. Jennifer Dingman is a long-standing patient advocate, a published author in patient safety journals, was also a co-author of the NQF Safe Practices Patient Safety Chapter, along with our other patient advocates. And she is the co-founder of Pulse, the American division, and has been a long-standing shoulder and voice and real heart to so many patients and families that have had patient safety tragedies. And so we'd like to ask Jennifer Dingman just to share 30 seconds of her voice representing the patients, and we'll get started. Jennifer?
Thank you so much, Dr. Denham, and thank you for allowing me to be here today. I just wanted to thank the audience for being here. This is a very, very important subject, particularly for patients and families, and I know that all of these webinars teach so much to the providers. I just strongly encourage you, when this recording is completed, for those who have not been able to attend, please share this with others, because this is very, very important material. We have excellent speakers, and I'm really excited, and I can't wait for this webinar to begin. And I'll turn it back over to you, Dr. Denham.
Thank you, Jennifer. And we just want to remind everyone that this will be available for free on demand by next week, and the slides and the audio recording will be there. Now, my job, and I'm going to be very quick, I'm going to go through a number of slides, is to address some things that are in the news, but also I'm going to address a number of our polling slides that really set the context for Dr. Huddleston and the rest of the presentation regarding the journey. Now, we have addressed a number of critical areas, and one of the areas that we have addressed in the last 6 months is a MedTac, medical tactical course program that we've been putting together on the 7 leading causes of death of children K through 12, but also, it turns out, through the workforce. And one of the exploding areas is opioid overdose. And this is an image from CNN of 2 folks and a child in the back seat who were pulled over by law enforcement. And it was so compelling in that when the folks woke up, as the officer was interviewing, they tried to drive off. and it's just an example of two adults that were overdosing on drugs. Now, very recently, CNN has done a documentary on the poisoning of America. We highly recommend it. The data that they share is very compelling, and it gives you some video and media to address this exploding problem. Here are just a few slides from slides we've created from this, but we highly recommend this documentary, and I know Dr. Boats, who will be a reactor today, will address this exploding problem, as well as we talk about our MedTech approach. But the cost of heroin has really made it so accessible, and now they're mixing it with fentanyl, which is having an enormous impact. And in the documentary, you'll see the exploding problem that they're seeing in the emergency department and the number of deaths that have been occurring in areas of the community. And one of the biggest issues is they're targeting our children and our communities in more affluent neighborhoods because they have the money to be able to focus on it. They use the power of story. This young man that you see in the upper right-hand quadrant tells his story, and this 16-year-old child's father tells her story, who died of an overdose. And these are wonderful kids, and kids, like we all know, in middle-class communities are just getting roped into this terrible, terrible problem. So we just wanted to make sure you were aware of this great documentary that you can use to help tell the story. Now, I'm going to walk through a number of articles that have been in the news. We're scanning the literature every week, and infection control issues are continuing to pop up. You're going to continue to see them in the press, and we are seeing them as we interview you through our polling and draw your attention to this issue regarding the superbugs and the drug-resistant infections. So critical to know that this is just going to continue to hit, and that and I think we're going to see a lot of press attention. Another topic is record mix-ups with patient identification and them leading to patient safety consequences and deaths. I think this is a Wall Street Journal article. This will help get the attention of the C-suite, who often read the business press but may not be reading our medical press. And we're continuing to see a bigger and bigger problem and recognition of mix-ups using the electronic medical records with patients. Also, Modern Healthcare had an article addressing this issue of patient identification, and when it hits Modern Healthcare, you've got a good reference for your CEOs and for your boards, and it addresses a bit of a breakdown and references the other articles that are a deeper dive on this topic. So we'd recommend that you look at that. Also, Medicare has set its patient safety goals, and we're seeing that this is going to continue to be a focus, and I think this can really help us make our case for hospital and healthcare organizations to focus on these areas and actually allocate more to the budgets of patient safety. October 14th, the article regarding the Office of the National Coordinator of Health Information Technology, increasing oversight and accountability. I talked to Ross Capel this morning, who we've had speak regarding EHR, patient safety issues, and he will be speaking to our audience in November or December and give us an update. He did a great job last year on healthcare, on the issues regarding EHRs and patient safety problems, and he'll give us an update in the next couple months. It'll either be November or December. Also in the press has been the focus on how the consumer rating systems for hospitals may have a problem in terms of data. We're not taking a position on this, but we just want to let you know this is popping up in the press, and you really probably need to be well informed regarding the pros and cons of using the data and these areas. Another issue, very, very topical, and Dr. Boats will ask him to respond to this and kind of give us some insights. But we've been focusing on these leading causes of death in kids through the workforce, and especially focusing on the workforce in hospitals and healthcare organizations. The Stop the Bleed program is endorsed by the White House, and it is very likely that the next generation of the way we've seen CPR grow into the community and help us get trained on CPR is going to happen with stopping the bleeding, and this was prompted by the active shooter events. And so we recommend this PSA, and you can see where you can watch it. And this focuses on everyone learning how to deal with extremity wounds and bleeding and wound management, and especially important because we're now seeing mass casualties and active shooter events weekly in U.S. hospitals as well as in schools. So let me shift gears now to our polling. We just wanted to remind you, and I'm watching my time to really give Dr. Huddleston and the team that has been in there in collaborative to share their journey. So I'm moving quickly, but I wanted to set up the polling results that we had after we did our webinar on standardization of emergency codes for hospitals. And so this is an area that was brought up by Bill Scharf of OSF. We did a deep dive on it and realized what an amazing opportunity it is to help organizations move to standardization of emergency codes and plain language and simple text, since many people are having challenges with multiple hospitals where they may work, all having different code symbology and names. One of the great organizations that has done great work is the Hospital Association of Southern California. After preventable death had occurred due to confusion regarding codes, they did a multi-site study across California and worked on a standardized code structure. And we addressed this, and we really recommend you to go back and watch our webinars on this, because we are going to take a deep dive on it. So we polled our audience regarding emergency code harmonization and said, are you interested in another webinar on emergency code harmonization? And we're seeing that that was positive. 70% agreed. You could see 32% gave it a 10. We stratify your responses on very strongly agree at 10, very strongly disagree at 1, but you see a bit of a spread there. We asked whether groups wanted to be involved in a national collaborative on emergency code harmonization, and you can see that there's some strong agreement. We are going to be working on such a national collaborative, and likely co-hosted with Texas Medical Center in Houston, and they have multiple organizations. We had a speaker from, two speakers actually, from Texas Medical Center and Texas Children's, and their journey along this path. So it looks like there's strong response from you. We ask you, the emergency code issues I would like to be addressed are, and I won't read this slide for you. Again, that's not the topic of today's presentation, but I want to let you know it's in the slide deck, and it addresses some of the issues that you brought up. So now to set up our topic for today, and we're 13 minutes after the hour, so I think we're right on time, is to address some of the polling that we did after Dr. Huddleston gave tremendous presentations July and August on the Mayo Clinic Mortality Reviews, and the collaborative that she and Mayo Clinic have started to help organizations get going on mortality reviews. Just to give you a picture of what you told us after we addressed these topics. I'm interested in deep dive webinars on mortality reviews and safety learning systems, and an enormous response. And look at compared to the prior polling, 68% of our audience, and we're representing hospitals and healthcare systems in 50 states, and these are in the hundreds of responses in terms of how many organizations. And when we see 68% giving it a 10, 19% giving it a 9, and only 1% down at the low end, we responded to your request on this focus. Now, these were the topics that you asked us to address. Again, they cover infections, they cover failure to rescue, they cover DNRs, they cover how to deal with emotionally difficult families, and a whole host of topics that I won't read off for you, because we're setting up our discussion that'll be introduced by Dr. Huddleston today. The topics in learning from the reviews were not only on one page. Just look at sepsis, how much sepsis jumped out, medication errors, implantation and the blame approach to opportunity to improve, coding inaccuracies, opioid overdose. You could see a number of topics popped on the grid there. So this is a slide that Dr. Huddleston will show us that she's used in every one of her talks, and this really opened our eyes to this issue of errors or harm due to omission versus commission, because we've really been focused on medication management and infections and a number of topics that kind of are right there in the middle. But resuscitation and procedures and failure to rescue and these issues of omission and diagnosis were topping the charts. So we ask you as an audience, are you interested, or have you declared, I am interested in a deep dive webinar on errors of omission, and look at the numbers. So Jeanne, you got a strong response to your presentation, and they really want to know more about the errors and patient safety issues regarding omission. We asked the question, would your hospital be interested in participating in a 100-case safety learning system collaborative? And a pretty strong response with 53% agreeing and 17% strongly agreeing, or very strongly agreeing, which is almost 30%. So we're inviting Dr. Huddleston to have dialogue with healthcare organizations, to invite them in the collaborative that will be addressed in our presentation today. And we ask, I'm interested in a webinar with speakers who have launched Mortality Review from scratch. Look at how strongly that you responded. Since you responded that way, that's why we set up today's webinar to have a team talk about their journey. So what we'd like to do is have Dr. Huddleston take over and set this up for us, because there's some folks that have not been heard the prior webinars, and this puts us back into the frame of mind and the context, and then we can carry it along the journey with Hanan Foley from there. So, and just a quick introduction for those of you that don't know Jeanne. Jeanne has done terrific work at the Mayo Clinic in this space. And when she was asked, well, what about the data and what about measurement, so committed was she regarding this as a hospitalist, she went back and got an engineering degree in order to really have the right communication skills and analytic capability to talk about mortality reviews. And with that, Jeanne, carry the ball.
Thank you very much, Dr. Dunham. And thank you to all of you who are participating. I see that there's already a couple of questions, so I will weave answers to those as I just briefly go through a summary of the last couple webinars through July and August and September, excuse me. So I'm going to share with you very briefly our story about learning from Mortality Review and moving forward, starting to learn from the living. So recently I was working with my Chief Quality Officer and asked her what she wanted her legacy to be, and she asked me if we could start learning from the living instead of instead of just mortality reviews. We've been doing mortality review work for over 12 years now. We've done more than 10,000 consecutive reviews of the deaths in Rochester and throughout our health system. So we're working at an enterprise level solution. And our journey started in 2003. Because we were frustrated with the global trigger tool and the fact that the data and the learning that we were getting from the global trigger tool didn't drive the initiation of a single quality improvement project. So we were putting a lot of resource into something but weren't actually acting upon it. So it didn't feel meaningful to us. So we understood, because of the recent IOM report at that point in time, think back early 2000s, that we were only getting the tip of the iceberg through our voluntary reporting system, and sincerely wanted to learn about what was going on underneath the water so that we could find something actionable and meaningful and make a notable change to the lives of our patients, their family members, and our providers. And so we thought, okay, if adverse events lead to death, then maybe we should start with the deaths. So Mortality Review started out for us as a convenient cohort to try to learn about our larger iceberg. easy to find, a denominator that people understand, easier to do data analysis with. And so it was literally just a convenient cohort. I think there's probably many other cohorts in the hospital and healthcare setting that we could learn from as well, but we started with deaths. It took us a solid 3 years, maybe more, to figure out how to do a meaningful review. And by meaningful, I mean something that engages nurses and doctors, increasing their activity in both the quality improvement and practice improvement space. And meaningful in that we came up with things that when we revealed it to our senior leadership, quality improvement projects were put into place and lives were saved. So that was our goal. The guiding principles that came out of that by creating a meaningful system were that we were doing system review and process review. We were not doing peer review. In those 10,000 plus mortalities that we've reviewed, you will not see a single physician or nurse name anywhere in the qualitative storytelling portion of our review process. Because what we find is those things that can happen, they can happen to anybody, not just a particular person or a particular doctor or nurse. The second guiding principle is deference to expertise. So for those of you who are engaged in high reliability organizations and moving in that direction, one of the key principles of HROs is deference to expertise. And we solidly believe that having a clinical provider, nurse and doctor, review the chart gives us a much better understanding of what the patient's experience was prior to their death. Everything's recorded centrally in a registry and an enterprise solution so that we can learn across hospitals, not just within a hospital and not just within a single discipline. And I think that the magic actually happens in our multidisciplinary, multi-specialty monthly meetings, where practicing nurses and doctors who are passionate about this work meet on a monthly basis and discuss the cases where opportunities for improvement were identified. And we've had critical care docs, surgeons, cardiothoracic surgeons, trauma, cardiology, hematology, hospital medicine, nurses from across the institution, our coroner, pharmacist, our sentinel event leader, and just interested clinicians come, and there'll be anywhere between 30 to 50 of us sitting in a room on any given time, and we'll be talking about the cases. And it is just amazing learning for all of us to see how things work throughout our hospital. Clinically, it's excellent learning, and we've all learned to talk with each other across these disciplines and departments about really hard stuff. So we've moved this out of the silos of the traditional M&M conference to talk across all groups. And then the other key principle is that implementation is local. So these are the guiding principles, but how the work gets done at each individual hospital or each individual area has to be a local implementation. This is a slide that you can review at some point in time. What I just wanted to point out is that our process that we developed is a combination of reviewer and committee work. So there's independent clinical people doing reviews, and then if either nurse or physician finds an opportunity for improvement, then that case is brought forward for the committee discussion, and any opportunities for improvement there are reached by consensus. So everyone in the room agrees whether or not this case had an opportunity for improvement and what it was. That information is then shared through a reporting process and a distribution of case reports. This is a slide that Dr. Denham just showed you. And what I wanted to point out is that 80% of what we found that we can do something about are omissions, not commissions. Commissions, as we know, the adverse medication events, procedural complications, all of those things are relatively rare. But omissions, I'm afraid, are not rare. The recent IOM report about improving diagnosis in healthcare, all we're doing with ours is finding everything that they've reported, but we're actually getting down to the granular population level and can actually begin to quantify it. If you look at this Pareto diagram, the two things on the far left, delayed or misdiagnosis and failure to rescue cases, our two biggest problems across all of our hospitals are omissions. You don't get into procedural complications until the third part of that Pareto, but then the ones after that, documentation and triage, those are omission categories again. And each of those have had major initiatives that we've been able to act upon because of this aha sort of learning that we've had. This is just a brief example of a delayed diagnosis, a 59-year-old female who underwent a total abdominal hysterectomy, did well until post-op day 3 when she developed some acute kidney injury, some urinary retention, and some new abdominal distension with markedly increasing pain. Next day, her acute kidney injury was worse. Her pain was much worse, but they stopped her narcotics because they were worried about an ileus. She ended up having an episode of paroxysmal atrial fibrillation, met our RRT criteria. On post-op day 5, she was hypotensive and developed diaphoresis and nausea. A rapid response team was called at that point, but they had no blood pressure palpable when they got there, ended up calling a code, proceeded with more than an hour of resuscitative efforts, and she died. In an autopsy, was found to have an abdomen filled with pus. So for 3 days, we missed the diagnosis, and for more than 24 hours, we did not call our rapid response team, even though our RRT criteria were being met. So this particular case had opportunities for improvement on delayed recognition of the deteriorating patient, delayed recognition of the diagnosis, communication-related issues in terms of physician responsiveness on multiple different shifts to nurses, and diagnostic opportunities in terms of ordering appropriate tests and following through on critical laboratory studies. So there were a number of opportunities in this particular case. The other thing that we've identified are the opportunities around end of life, and this is something that's ubiquitous to what every hospital in our collaborative is identifying as well. But our point in doing this is the opportunities that we're looking for aren't just about they're not about preventability at all, actually. In this particular case, this was an 82-year-old with pancreatic cancer who was hospitalized for a bowel obstruction. And in the last 24 hours of his life, his average pain score was 8 out of 10. And so we've started moving toward, much more aggressively, the concept of not only understanding where our omissions and commissions have led to increased illness that the patients experience or maybe even death, but where are our omissions and commissions actually preventing our patients from having a good death, one with dignity and comfort with their family around them. And so we're really looking into this space right now, and this one particular case here led us to doing some significant initiatives around palliation at the end of life and goals of care discussions. All of these things that I've talked about are system failures. When you miss or delay a diagnosis in one patient in one place, people typically get a peer review letter with a description of how they could have done better. But when that same diagnosis is missed in the same quarter in 5 different places in the same hospital by 5 different providers, that's not a peer review issue anymore. That's a system issue. And why aren't our systems supporting our providers so that they can actually do their best work every day? And so we look at it from that perspective and supporting our nurses and doctors and helping them deliver the care that needs to be delivered to the patient when the patient needs it. This is just a brief story about our triage errors. We recognize that when patients have triage, when we put them in the wrong place in the hospital when they first come in, whether it's out of our emergency department or a direct admission, they have a 62-fold increased risk of death. We had been begging our hospitals for an improved triage process for probably 20 years. And when we found there were 10 deaths in 1 month when we were doing the reviews in the mid-late 2000s. And within 6 months, we had a new triage center. So we have gone from having up to 10 deaths a month related to triage errors to less than 1 per year when we fixed that system. The other one of our big successes, we had 5 unanticipated deaths in elective orthopedic patients in 1 quarter about 7 years ago now, gosh. And we went through our typical sentinel event process, and nothing was identified as being a problem because all of the protocols were followed to the letter. When we looked at it from a mortality review perspective, when we saw this cluster of patients, we recognized that all of them had undiagnosed obstructive sleep apnea and had died a respiratory death in the first 36 hours following surgery. We put into place a screening process preoperatively for all patients. We identify those at risk for obstructive sleep apnea, and if they are at risk, we treat them like they have obstructive sleep apnea postoperatively, have a remote respiratory monitoring protocol in place. And since this was put in place, this screening and this monitoring, we have not had a single narcotic-associated death since the end of 2007. Our structure, our organizational structure is twofold, and it's twofold intentionally to meet the needs of the organization and our patients. We have the review team that reports up to our CPQOS as our Clinical Practice Quality Oversight Subcommittee. MORT is our mortality review team. They're responsible for doing all of the reviews, making sure the work gets done, and telling the patient's stories. We broke the data analysis and the quantitative portion and report generation part out of that particular group, because as soon as that group of people started having to do all the data analysis and report generation and trying to fix things, they didn't have time to do the reviews. So we intentionally separated those so that those doing the reviews, their time is protected, they're safe, they're not going to get pulled into other things. We believe that what they do is sacred to our mission in improving care. Then we have a separate group following Six Sigma analytics approaches that does the analysis, interpretation, and ensures data integration into our other safety activities. What we end up with as a result is a combination of stories and data that we can inspire and hopefully motivate our senior leaders to make changes within our institution. This is just an example of one of the charts that we create, our statistical process control trait. This is our mortality between the years of 2008 and 2011, and it demonstrates that in 2009, we put in 6 different initiatives around rescuing deteriorating patients, sepsis, and triage that I mentioned, and as a result, did see a statistical reduction in our mortality rate. It wasn't any one of those projects, but it was the combination of them addressing things that we knew were causing harm and leading to death that we were able to reduce our mortality rate. Our system also does heat maps, so you can see in this particular, looking for hot spots in our hospital, these are all the failure to rescue deaths and delayed diagnosis deaths that occurred in our hospital between 2007 and 2014. And you can see one hospital one floor in our hospital is bright red. And when we looked at it through time, so the same floors on the vertical axis there and the years at the bottom, you can see it wasn't that floor all those years, but something clearly changed in 2014 on that particular floor. We were able to identify what that was and address it. And so knowing where these things were happening in our hospital was crucial, which means for our review process, we do burden the reviewers with adding in where they saw the opportunity for improvement, when it was, and who was taking care of them, because without that information, who is in what service line, cardiology, hospital medicine, without that detailed information, we cannot get to the meaningful analytics that can actually drive the change. And I'll close with our iceberg diagram. This is what I call this. Every 2 years, our institution says this takes too much time and too much resource. Must we continue doing it? And I create this iceberg diagram that shows for 2013 to 2014, we had 1,905 deaths. In those deaths, 45 patients had, in the lavender circle there, 45 unique patients had adverse events associated with harm, and those were voluntarily reported. In our surveillance, electronic surveillance, there were another 21 patients, unique patients identified who had hospital-acquired infections. And then you can see the mortality review system events. We had 263 unique patients not identified anywhere else that had opportunities for improvement that would have been missed had we not been doing these reviews. Every time I show this to our leadership, we get the nod to keep going and recruiting as many people to work on the process as we can. Why does it work? I believe it works because we moved away from insular peer review and broadened and discussed things across all disciplines and departments. We promote culture change as a result of that multidisciplinary, multi-specialty voice, and also promote culture change because of a deference to expertise. And finally, it's not about adverse events. We don't even use those words. You've heard me talk about opportunities for improvement. We also use the word issues. We all have issues. Our teenagers have issues, etc. So we're comfortable using that language. So we use that social culture and brought it into our review process. And we just have frank conversations about the stuff that's going wrong in our hospital. Because it's not about preventability. It's not about whether or not the death was anticipated. It's not about attribution. We want to identify the processes of care and the system failures that are leading to harm. And we want to identify those as opportunities for improvement and therefore create the ability to inspire action through stories. Finally, the most important thing to our Chief Quality Officer is our ability to right-size our quality improvement initiatives. When we found out the delayed and missed recognition of deteriorating patients was happening in every hospital, it became an enterprise-wide quality improvement initiative. However, when we had an event that happened to a patient on one floor in one hospital, we didn't need enterprise-wide resources. We just needed something on one floor. And when we found we had something in two hospitals but not in a third hospital, we just needed to change protocols in two hospitals to match the third hospital. And so it has really allowed our Chief Quality Officer and our other patient safety leaders to figure out exactly how much resource needs to go towards fixing something. What about the living? I mentioned that earlier. So our next journey is we created the collaborative that Hanan will speak about. And we wanted to do this because we wanted to sort of expand beyond mortality review and into learning from the living and to see if this mortality review process could actually be expanded to different populations in different hospitals as well as in different cohorts. So we're now calling it a safety learning system. It's the next generation of organizational learning aimed at identifying opportunities for improvement in other challenging cohorts in addition to deaths. In addition, we've added a human factors taxonomy. So for us, our difficult cohorts now that we're trying to get our arms around are readmissions, our high-cost cases, so we're looking at 100 of our highest-cost cases from this year, respiratory failure. So in our delayed or missed recognition of deteriorating patients, respiratory failures are our most common thing now, not sepsis. Hotspots, like that floor I showed you that turned up red. We need to be able to look at our hotspots and see if we can evaluate what's going on from those processes and systems. And finally, sepsis, yes, it's still the bane of our existence in many areas. And then PSI-4 keeps coming up for us as something we need to understand. So we're taking this methodology and using it in these other difficult cohorts for us to try to fix, those ones we haven't been able to get our arms around. And we're seeing what we learn and what we can actually change as a result. The tenets of our safety learning system are exactly what I mentioned before, and I put this in here as a summary because this is what we're taking forward to the collaborative. And these are the folks that are participating with us in the collaborative. There's 41 hospitals in all who are participating both in Australia and in the United States. And Hanan, I turn it over to you.
Thank you so much. Boy, you know, every time we hear you speak, Jeanne, you're adding new layers of incredible insight that I think are directly applicable just across the board. So thank you so much for introducing this, and I think it beautifully complements the other webinars that you've led. So thank you very much. Hanan Foley, we want to thank you so much for speaking about your journey. You saw from our polling results that folks really wanted to hear from one of the collaborators, and it's just fantastic that you and your team have stepped up. Hanan is the Director of Quality and Safety at MedStar Georgetown University Hospital. Her healthcare career spans over 35 years, where most of her time has been spent in critical care nursing and quality improvement. She's functioned as an adjunct faculty at the Department of Health Systems Administration at Georgetown University School of Medicine and Healthcare Studies. She's an advisor to the IHI Open School students, and she has a bachelor's degree from American University in Beirut and a master's degree in nursing administration from Georgetown University. And we'll count on you to kind of share who's on your team and the work you've been doing. But thank you so much for stepping up and addressing your journey in this collaboration.
Thank you, Dr. Denon, and thank you, Dr. Huddleston. Good afternoon, everyone. And maybe good morning to some of you, depending on your time zone. It's my pleasure to present to you today on our mortality review journey. Before I start, I'd like to say that there's nothing for me to disclose. And I want to mention the objectives for today quickly. I will first provide some background on MedStar Georgetown University Hospital's mortality review. This is needed because this will set the stage to discuss why we joined the Mayo Collaborative. Then I will highlight some of the challenges and obstacles that we have been encountering. At the same time, identify some of the helpful strategies. Finally, I'll provide some initial lessons learned as we started identifying opportunities for improvement. Some information about MedStar Georgetown, and I will be referring to it MGUH throughout my talk. It's a not-for-profit acute care teaching and research hospital in Washington, D.C. We are part of MedStar Health, which is a 10-hospital system and the largest healthcare provider serving the greater Baltimore, Washington, D.C. region. We have several centers of excellence at Georgetown to include our Lombardi Cancer Center, Neurosciences, Transplant Institute, Tertiary GI. We have been awarded magnet status by the ANCC 3 times, and we are currently working on our 4th designation. MGUH has about 4,900 staff members. Around 1,000 are physicians. We are licensed for 609 beds, and in fiscal year 16, beds in use were 428. Our annual inpatient admissions, about 16,600, with an annual outpatient office visits of 980,000. And our ER visits were just above 34,000. As to mortality review background at MGUH, I'd like to first mention that we did not have 100% reviews of all mortalities in all services, especially in internal medicine. Some services did have 100% reviews, but not internal medicine, where most of the deaths occurred. And the reviews were done in silos, in each department, in M&M conferences. There was no formal process for case selection, and the standards for the reviews were found to vary widely among departments. They were more or less peer review exercises done only by physicians, not multidisciplinary, and there was no organized or formal way for knowledge sharing and transfer and follow-up. I also want to mention here, I know my slide does not include it, that our mortality index is not where we need it to be. We definitely need to tackle this by assuring accurate and adequate documentation and coding to really capture the correct mortality risk of our patients and increase the expected rate. But we were also very interested to and wanted to really improve our processes of care and care coordination. So with that, in summer 2015, in July, MedStar Health as a system decided to join the Vision, then the UHC Enhanced Mortality Review Collaborative. It was a very helpful 9-month collaborative that started us on this new journey. We developed our charter, and at the time we focused on the top 5 services contributing to our mortality rates. And we aimed at developing a standardized process for review, incorporating a 2-level approach. Then we established our core mortality review committee. It consisted of 3 physicians from hospital medicine, pulmonary critical care, and transplant, quality director, which is myself, and one of the quality coordinators, a nurse risk manager, a nursing clinical manager and educator, and a data analyst. Early on, we started encountering challenges and obstacles on both the structure and the process. We struggled with the content of the review, what data elements to capture, the semantics, how to develop a standardized review form. For example, should we have a 1-tier or 2-tier review? Should we call it a level or a tier? Are these levels used to trigger a deeper dive, or are they going to be used as a screening tool? Whether to classify the deaths as anticipated versus unanticipated, whether they were preventable and non-preventable, all the semantics that were talked about by Dr. Huddleston just a few minutes ago. And the list goes on. We were bogged down with really getting our reviews done. I need to add here that the first level reviews were actually done by the one quality coordinator, and the deep dives were done by her or some of the physicians on our team, and then we will discuss them together as a group to try to come up with the OP. In the UHC collaborative, Dr. Huddleston was one of the main subject matter experts, and as you could tell, she's a dynamic and an inspiring speaker who presented on at many of the calls. And during one of the calls, I expressed our concern that we are not able to get the process off the ground in a manner that will really support having learning from every death enculturated in the organization. Really, we wanted more help on the how rather than the what to review, how to move the process from the review stage to the reconciliation to really finalizing the opportunities and being able to recommend improvements. So at that time, Dr. Huddleston offered to discuss this with us offline, and she did, which we are thankful for. She presented to my core committee members and shared in detail the intricate workflows that they refined over the years at Mayo. And then it was clear to us all that at that point that the Mayo approach presented itself to us as an answer to our struggle. I took this to my senior leaders at MedStar Georgetown at the MedStar system level as well. And the decision was made that the MedStar Health as a system will join the Safety Learning System Collaborative. So let me summarize again why the Mayo approach was the answer for us. First, they are viewed as the experts in learning from every death. They have had over 13 years of learning iterations, how to conduct robust system reviews, and how to generate OFIs and organize data. Their multidisciplinary system learning approach, that focuses on the processes of care and not just a peer review approach. The non-punitive philosophy, which actually goes hand in hand with our adoption of just culture at MedStar, and the philosophy of learning and not judging. To have nurses and doctors come together to tell the story, and looking for opportunities for improvement even in expected death situations. So the fact that they had their process refined over the year, and that indoctrinated process was very attractive. I need to mention they had excellent mortality metrics. And this was a research study, and we very much wanted to join that, and we have a MedStar Research Institute. Also, what was attractive is having Dr. Huddleston come in person to provide some training opportunities. So all this, was the catalyst for getting our project off the ground. So, after the decision was made, our first steps were to assign roles to the members of the core committee, which was already established. So that helped us. We already had a core committee for mortality reviews because of the UHC collaborative. So we followed the recommendations of Dr. Huddleston. So one member of the committee could function in more than one role. So we have the PIs and the quality safety leaders who are responsible for holding the monthly meetings and the discussions about the OFIs, and who are responsible to communicate learning and to interpret local and benchmarking data, among other functions. Also, we had operational leaders who are responsible to assign the cases to the reviewers, to prepare for the case discussions, and to finalize the OFIs and prepare the summaries. Plus, we had reconcilers who would, together compare the OFIs that are, the OFIs that are determined or identified by the nurses and the doctors, and if there are any errors or any differences, they had to go back and do a focused review in the chart to really come up with the OFI or with the final results. And the reviewers who were supposed to review the cases in a timely fashion and attend the monthly committee meetings. So after that, we embarked on a recruitment spree for reviewers, because we did not want to have all these deaths being reviewed by just a handful of people. So we wanted as many nurses at all levels and as many physicians from as many services as possible to be reviewers. And after, with having some of the reviewers, we started the training by Dr. Huddleston, and we currently continue to conduct individual training because we continue to recruit new reviewers. I already mentioned that this is actually a system-wide initiative. So here's our timeline. And as I mentioned, in July 2015 is when MedStar Health joined the Visions Collaborative, and then it was sometime in March of, I don't know if you can see this, in the decision to join the Mayo Collaborative was in February, where Dr. Huddleston actually came and presented to the whole system, to all the committees from all across the system. And in May, we had our first training by Dr. Huddleston at Georgetown. Then she actually came and conducted our first committee committee meeting, to help us, move us through the process and help us use the system and identify the OFIs and the causing factors. And I know that the study is was supposed to end in November, but now it's extended through, I believe, March, and we're happy with that because really it's taking more time than we thought it would. So what has worked for us? First and most importantly, the executive support. Yes, I can say that we did not have FTEs allocated for this initiative, but our VPMA and our Associate Medical Director for Quality and Safety, both of them are reviewers, and they attend our meetings. And that in itself had a great impact. We have 3 physician champions from different specialties, as I mentioned before, and they're very invested in the process. we have a project manager, and this was a huge help, because this initiative is really a big undertaking, and we really needed someone to keep us on track, to handle the communication with Dr. Huddleston and her team whenever issues arise with the system, to really follow up with the reviewers when they're not finalizing their reviews. So our data analyst is actually functioning as a project manager. Finalizing the cases also take time. So even after the committee meeting is done, we needed to meet and finalize the cases and make the summary. So, and I'm very thankful that one of the quality coordinators who actually initially in our journey with the UHC collaborative was actually conducting the most of the reviews, really took on the task of finalizing the cases when other operational leaders did not do it. And again, having a set date for the committee discussion every month is very helpful. I really recommend that. I know at the Mayo Clinic they had Mortality Tuesdays. I don't know if that was the right day, Dr. Huddleston, where, Mortality Tuesdays when they do the have the committee meeting. So at Georgetown we have Mortality Fridays. It's the first Friday of every month from 12 to 1. And it's open for, at the moment, it's open for the reviewers and the core team, and it's about 30 people who attend. And providing lunch at this committee meeting really helped. Challenges, and we are encountering challenges. The recruitment and retention of reviewers. As I mentioned, this is, we underestimated the time commitment that's required. Especially now, we are still at the very early stages. We're learning how to review, how to use the system, so, and we don't have FTEs allocated. So this has been really a challenge. Plus, we have other initiatives happening at the same time throughout the organization, and we really need to, devote time. We feel like we need the resources. The reviews were taking more than 20 to 30 minutes because of the steep learning curve we had to overcome. At the beginning, some reviewers are telling me they're spending hours reviewing a chart. So we're learning, and I know that now it's not taking as much. We are also dealing with different electronic medical records and systems, and we have some of our physician documentation in some areas are still in paper. So hopefully within a year we're going to be completely, we do have CPOE, but some of the physician documentation is still on paper. So, and there were there's no interoperability between the systems and with the Mayo system, so there's lots of manual entry of some demographics into the system. So that was a challenge, and this continues to be. The other thing that we realized about the reviews is that reconcilers had to go back to the chart and actually redo the reviews. It's because the opportunities for improvements are not really written in a meaningful way to really understand what's going on. So we felt that we had to really retrain the reviewers to show them what a good example of an OFI is, so we don't redo the work of the review. And many times the other category has been utilized rather than choosing the appropriate category from the drop-down menu. I'd like to also add that we did fall in the trap of having a peer review mentality, and we kind of noticed it during our committee review sessions, the committee meetings, but I think we're doing much better to really turn away from the peer review mentality and really focus on the system failures. Our opportunities for improvement, one of the questions was, are we finding OFIs? And we do. And actually, I did ask my colleagues at the other hospitals, and we all share what you have on the slides. We definitely had opportunities, end-of-life opportunities, like better utilization of palliative care and better transition of care between the acute care facility and like aftercare settings. We we identified pre-admission triage opportunities where patients transferred from other hospitals were admitted to the wrong level of care because of the handoff process, and there's a group working currently on having a structured handoff and a clear policy on how often the update needs to happen if the transfer is delayed. We did identify communication issues between services, between primary services and the consultation teams. Yes, we did identify delay in escalation of care, delay in diagnosis, not following protocols, and many documentation issues. So this is a workflow that shows where we are with at MedStar. As I said, this is a system initiative. We don't only want to learn from our lessons here at Georgetown. We really want to learn as a system, learn from each other. And so the area in red shows what I just described to you, how the review moves from the reviewer to the committee. But then we will also, it shows how we're gonna how the learning is gonna flow to the upper to the different practices and the practices at the leadership, both at the entity level and at the system level. Again, as Dr. Huddleston mentioned, our role is actually identify OFIs and recommend opportunities for improvement. But our role is not really to prioritize what actionable, what initiatives, what quality initiatives that need to happen. We will leave this to the leadership. So what are our next steps? We definitely need more formalized training. We are considering system-wide training material, plus we're very thankful Dr. Huddleston has offered to provide some more training because we continue to have new reviewers as we lose some, and that is definitely something we need. We will be opening the committee meeting to everyone in the hospital. I know Dr. Huddleston said she gets about 40 people on their monthly committee meeting days. I mean, we are getting 25 to 30 now with all the reviewers coming, but we definitely want to open it to everyone in the hospital, not only to the smaller team. We are working on how the case summary will be distributed through the organization, and we haven't started aggregating the data yet, but this will be our next step. And as I mentioned in the previous slide, we are finalizing the workflow on how shared learning will happen at the system level and how we're going to recommend for improvement. So with that, I am done, and I'm open for any questions, and I will turn it back to you, Dr. Dana.
Well, thank you so very much for talking through your journey. And I know Dr. Huddleston will kind of now, what I'd like to do is have Dr. Greg Boats kind of react to both of you, and then go to Dr. Huddleston to have her give us some insights and the advice that she would share with any organization contemplating starting this journey. Dr. Boats is well known to, so I'll introduce him and give him his quick bio before we ask him to react, and then go to Dr. Huddleston. But Dr. Boats is a professor of the Department of Critical Care at the University of Texas MD Anderson Cancer Center. And he went to Georgetown School of Medicine and created his internship at Huntington Memorial. He went on to do a fellowship at Stanford with Dr. David Gaba, and he's boarded in anesthesia and critical care. I think most importantly, he has enormous passion for patient safety and really helping us lead the way this year in multiple areas, including some of the other topics that we covered. But, pardon me, but I know when Dr. Huddleston first presented, I was receiving texts from him on how important he thought her work was and how terrific her presentation was. So I know he's a real advocate of this process. But Greg, would you please react to what you heard from our first two speakers, and then we'll go to Dr. Huddleston regarding advice to those that would like to embark on this journey. And then we'll go to Jenny Dingman. Greg?
Thanks, Dr. Denham, for the opportunity to comment on this fantastic presentation. I think I can speak for most of the audience. I've been working in patient safety for many years, and this work is so exciting because it moves us from reacting to safety issues into the realm of actually understanding and managing these. I like Dr. Huddleston's description of a safety learning system approach in institutions and in systems. This is very much like the safety management systems that have been in place in aviation and transportation, where you manage your safety profile as well as respond to the safety issues you have in any particular mission or in any particular area of your organization. It moves us from reacting to safety issues to actually measuring and managing safety. That is so exciting because that's something that I've wanted in my work in safety for years and never knew how to actually get there. Going back to the very beginning, I think it's important for all of us to realize that the image of the iceberg is very important. So often in performance improvement and patient safety, we think about reasons Swiss cheese, and we don't understand that there's a much larger risk and vulnerability to our patients and our systems and our caregivers that lies under the water, and we don't see it, we don't recognize it until it really can cause damage. That's a very, very helpful image to understand. The more we can move towards measurement of acts of omission and commission and understand how our system failures put our caregivers and our patients and families at risk, the better we are at understanding our risks and vulnerabilities. It moves us from episodic work to more of a continual view. And I think it's been particularly helpful to see MedStar Georgetown's journey into this system. I think seeing a practical implementation of this system was very helpful in understanding not only the gains that are potentially there for the system, but also the challenges that lay ahead for those of us that really want to be involved in this sort of work and implement these things in our institutions. It gives us perspective about things to expect along the way. I'm very excited about this process. I'm very excited about the results that I've seen, and I look forward to continuing to hear good results and to work on this process with many of you.
Thank you, Greg, and we're excited to have Dr. Huddleston come down to Houston and host her there in November to help expose her to some other facilities. Let's go to Jenny. Jenny, do you want to react now and take your phone off mute, and we'll wait for Dr. Huddleston to come back on.
Yes, it was for me as a patient and family participant. This was very, very interesting, and a lot of things I didn't really understand, but I'm just really grateful that they're doing this. But I can't stress enough with regard to mortality in patients, one of the biggest issues in the loss of a patient and related to harm in healthcare is the lack of listening to the patient and the family. I've done extensive work and research myself on this, and outcomes always appear to be better. When the patient's family is listened to, I'm strongly encourage hospitals to get rapid response teams initiated by families and patients and also people visiting patients because of the failure to rescue, which I believe was a very strong issue long ago, and it still is, failure to rescue. So when you take that voice of the patient and the patient's family and you utilize that and make that part of the team of the health care that you are delivering, I think that could really, really help and make a difference. And, of course, there are some things that you just can't do anything about, and, of course, that's understood. But I just applaud the work these wonderful physicians are doing in their hospitals, and I am so impressed. Again, I just want to encourage everyone here to share this webinar and other webinars like it for your colleagues, because these webinars have done great things, saved so many lives, and helped so many medical professionals improve the services that they're providing to patients and families. Thank you so much, Dr. Denham. I'll hand it back to you.
Jeanne, now could you help us understand the advice that you can share with those that are contemplating going on this journey now that Hanan has given us a picture of what their challenges and their opportunities have been?
Sure. One of the things that I've seen at all of the hospitals that are participating are three important key pieces to the recipe before beginning. One is making sure the leadership buy-in. So Hanan spoke to that beautifully. And the other piece is physician engagement. It does take time to look at these charts. And one of the things that's different about our approach is that we don't screen the cases and hand over the cases to the docs that have a readmission in them or a HAC or an HAI or something along those lines. We let the physician go at them cold and actually look for the opportunities for improvement, which is why we were able to identify the omissions, because we didn't screen out everything and just give them the commissions to review. So it does take some physician engagement. Often there's conversations regarding if you're going to support the physician's time, either with RVU recouping money or with paid FTE or something along those lines. We've avoided that as much as possible so we limit the number of reviews that anybody does in a week. So there's multiple strategies around physician engagement. Another is nursing engagement. Most of the hospitals are struggling getting practicing nurses to review these charts. They see it as absolutely crucial because I can tell you when a nurse who works on a floor reviews the chart, they see the omissions in terms of the care that's missed or a protocol that's not followed or something that happens with aspiration or a Foley catheter, that someone who's not actively embedded in that practice would likely miss something. And that's one of the key parts of doing the reviews is we're actually looking for the gaps in care. And it's very difficult to find what's not there. And so someone who's clinically trained and actively engaged in the practice, it's much easier for us to see what should have happened when it's not there. So clinical engagement is a really key component. Willingness for your leadership to react to the data. So I would have stopped this work, if we've been doing it for 13 years, I would have stopped this work 10 to 11 years ago if our leadership hadn't been moved by our work and been willing to make meaningful change to prevent these things from happening. There is nothing more demoralizing than watching people die and finding the same opportunities for improvement month after month after month and nothing happened. And so in order to continue to engage people to do the work, the leadership has got to be willing to respond and make changes, which is why having the combination of the patient's stories and the analytics to take forward and package it up really nicely for leadership so that it's easier for them to make the decision to make an improvement is crucial and has been a key component in our work. For anyone that's interested in participating, this collaborative existing group is going to be finishing a study, but there's been a number of questions that have come up around the omissions and actually doing some more work in that area. So we are going to be doing a sort of rolling addition of more people into the collaborative. There's 2 other sites right now going through the process of getting ready to join us, and we would love to invite anybody who's been involved in these TMIT webinars to please join us. My contact information is in the slide deck.
Fantastic, and we're going to continue to go through. Jeanne, while we do our polling, take a look at the questions that are being asked in the Q&A section in the lower right quadrant of the webinar. And I'd like to ask our audience just take a minute to fill the poll out, and that'll help guide us going forward. And so if you see the poll in the lower right-hand corner, I'm going to go through a couple polling questions. The first one is, I am interested in an all-cause harm approach, integrating mortality reviews for patient safety and risk management. So an all-cause harm approach, and this is an area that Dr. Boats and I are working on right now, of including patient safety but not limiting it to patient safety, an all-cause harm approach to your organization that can include the active shooter events and a number of other things like cyber crime that can impact patient safety into an all-cause harm approach that focuses on your people, those who serve, and those we serve. So it's not only patients, but it's also caregivers, as well as property, as well as your prominence or your reputation of your organization. We're going to take an all-cause harm threat approach and incorporate Jeanne's wonderful work and the patient safety work in that. And we'd like to know, are you interested in seeing an integrated approach of mortality reviews with the other areas of patient safety that you're working on and perhaps other areas of risk management? So we'd like to get that answer. The second question is the all-cause harm topics that you would like to have included in that. So our first question is, would you like it? And the second question is, what would you like to have included in that so that we can make sure that we cover everything that everyone on the webinar believes might be important for all-cause harm. This is the whole area of omission and commission, but even more broadly, the professional reputation of your caregivers when an event occurs, the second victim, how the organization handles that and make sure that we are protecting the professional reputations of our caregivers when they're involved in a catastrophic event with a patient or in a larger event that affects the organization. The second set of questions are regarding health information technology and health records, the EHR and the HIT areas. I'm interested in a webinar addressing the latest update in electronic health records, the electronic medical record, and the patient safety issues that revolve around that and the risks that we're seeing on patient identification and the other glitches that we're seeing that are causing patient safety accidents, and health information technology errors that are more broad in terms of technology that is using digital technology that might relate to pumps and alarms and other areas. So the question is, would you like another update on that? And then the topics that are keeping you up at night that you would like to address on electronic healthcare records and health information technology errors and harm. We'd like to know the areas you're worried about that's keeping you up at night. We always cover the ECRI list, but we know that there are other areas that are important. And then the final set of questions are, I'm interested in a webinar addressing the latest update regarding errors and harm and caregiver blame and HR issues. We're seeing a tremendous number of problems and challenges when a caregiver is involved in a catastrophic event that harms the patient, and it goes into risk management. And then caregivers are very worried about their professional reputation, their HR files and records. And we know the study that was done by ARC of 600,000 caregivers revealed that over 60% of them are afraid and anxious that this is going to impact their HR record, and many of them it does. And then the topics regarding caregiver, staff blame, and HR issues that you want to have addressed in future webinars are. And so we'd like to know, what are the topics that are keeping you all up at night or that you're having problems with that might be really important on that issue. And so I want to come back now and thank you very much for your polling responses. It'll help guide us. It becomes our compass that helps us along the way. I'd like to go back to Jeanne and have her address some of the questions that have been that have popped up in our Q&A panel, so we make sure that we're good servant leaders to the audience. Jeanne, do you want to tackle some of these questions that have popped up in the Q&A panel on the right lower part of the screen?
Absolutely. So I think I'm sorry, there's construction going on behind me, so I hope you can all still hear me okay. From the mortality review and peer review, and Hanan could probably speak to this as well, this is a really, really difficult spot. The training that we do is standardized amongst all sites. It was developed here at Mayo, and we had to figure out how to get doctors' heads out of peer review and into actually looking at the system. And what I ask them to do, especially the ones that are struggling, because they'll as clinicians, we're really good at saying, oh, that patient was really sick, or, oh, that patient was going to die anyway, or, oh, that patient had, just the list of what I call excuses of why we're not willing to call something an omission specifically. And so I ask them to make them ask themselves a very particular question. If that was your mother, or your wife, or your daughter, or your son, and you watched that blood pressure sit below 70 for 4 consecutive hours, could you have sat there and just held your loved one's hand and not done something? If the answer is you couldn't have just waited for the care team, you would have wanted to act yourself, then that care wasn't good enough for your loved one, therefore it's not good enough for your hospital. And that's the only we actually had a nurse in one of our monthly conversations when we were debating about whether or not something was an opportunity for improvement, and she just asked a question. She said, hey, if that was your mom, is that care okay? And all of us sort of looked at each other and said, no. She said, then it's an opportunity for improvement. So using that now is our standard for what we call an opportunity for improvement, and that is that one act, and getting docs to do that gets them out of peer review and gets them more about looking at the patient's journey and how that journey could have improved for that patient. And if the system is improved, it will then improve for thousands of patients. The magnitude of being able to impact a system instead of a quote-unquote preventable harm is magnitudes more powerful than looking at one particular event.
Jeanne, Jeanne, I'm going to, just in case Greg has pulled away on clinical issues, and we'll come back to have you answer the questions there, I just wanted to mention that we worked with a hospital that did over 1 million imaging studies a year, and their policy handbook was enormous, and we got 150 people off site and said, let's just pretend that the only policy you had was the golden rule, and that a family member, that the order for the imaging or whatever the process was with imaging was your mom or your dad or your loved one, would it change the behavior? And we came up with almost 200 different things to fix and didn't have to open the policy book. They were just standard things that tied back to that family member question. But before Greg may have to sign off for his clinical duties, and we're so grateful that he did, and then I want to come back to you and Hanan to be able to comment on some of the questions. But Greg, before you leave, I'd like you to make the pitch to Stop the Bleed and why Stop the Bleed is so critically important. We've just recently gone through, I went through the training. I think it's terrific. We're actually putting programs together, and this is something that I think any healthcare organization needs to consider as important as CPR. But Greg, could you kind of tell a quick snapshot of the background of Stop the Bleed, which I put back up on the screen, and why it's so critically important in case we lose you, and then we'll come back to both Jeanne and Hanan.
Well, thanks, Chuck. I am a strong advocate for Stop the Bleed training, which is a public access to hemorrhage control program that is now being promoted across the country by the Department of Homeland Security. This is analogous to the public access to defibrillation movement that went on about 10 or 15 years ago, where we learned that putting devices in the hands of public providers, not necessarily healthcare providers, to provide early defibrillation saved lives. Well, we know that the people that have bleeding injuries from either industrial or violence acts can die very quickly if you don't stop the bleeding. And so the effort now is to put bleeding control kits in public places like where we have AEDs to allow someone to get their hands on a tourniquet and a compression dressing to stop bleeding from an extremity that would otherwise lead to exsanguination before EMS or other healthcare providers could get there to provide care. We're seeing it's very easy to teach these courses. It takes about 2 hours to go through the curriculum and teach people how to use a tourniquet and a compression dressing safely. And I think it's going to have a lot of impact on the health of our communities as we see acts of violence and industrial and community accidents that lead to significant bleeding continue to grow.
Thanks so much, Greg. And now, in case we lost you to your clinical duties, I didn't want to miss the opportunity to have you kind of reinforce that for us. So back to you, back to both of you on the advice to organizations that would love to embark on this on the journey, especially in engaging your leadership teams, because with resources pretty tight, it's very hard to get organizations to think of adding one more program. And maybe Jeanne tackle that, and then Hanan, would you tackle it, and then also any of the questions you think that you'd like to address before we finish. We have about 3 minutes. We always like to finish on time.
Just briefly, I'm going to cover just a couple of the questions, and then I'll answer the question about adding something, yet another thing to organizational work. Juanita asked a question about 100% cases reviewed. MedStar went in all hands on deck from the beginning, intending to do 100%. My coaching typically for hospitals, and it's Hanan's enthusiasm for this thing, but my coaching typically is do 100 cases. See if this is a meaningful process for you. If it's not meaningful, don't waste your resources. Don't do it. But if it turns out to be meaningful, you'll know in the first 100 cases. And for smaller hospitals, we have critical access hospitals doing this work. And then they don't do 100. They do about 20 to 50, depending on what their mortality rates are or the volume of deaths that they actually have. So any size hospital can do this, and you can try it to see if it works without going all in. We do not involve patients and family members in our review process. We speak with patients and family members when they request to know information, because those of us who have done the reviews know the patient's journey from a provider perspective the best. Hanan, are you guys going to be including patients or family members?
Well, currently we are not, but I just want to say that we do have a Patient and Family Advisory Council for Quality and Safety, which is a very active group, and they're involved in many safety initiatives, and this is on our agenda. But again, we want to finish the 100 consecutive death reviews, and we're in our early stages before we can formalize how we can include them in the review. And we do have, as I said, the PFACs. We do have care for the caregiver, and we have disclosure that happens right away. So really, we are way ahead in that aspect of disclosure and caring for the caregiver and involving the families. As to the question on can we do 100%, we are committed to the 100% at this stage. We're going to do the 100 consecutive reviews. We will reevaluate to see if there is, and actually we want to wait for the research study results to see if there is value in having the screen, and not really go into a deep dive into every chart. So we'll wait and see what the research will tell us about that. But again, physician involvement and executive leadership support is definite is a must. I noticed one question about you mentioned something as having the staff nurses being involved. We had 2 nurses who were on light duty who thankfully were able to come and join the team in the past months, and the value they added to the discussion was paramount. Everybody noticed how our last committee meeting was so much different because they did identify gaps in care. And even just being in that committee meeting, it was really just great, beautiful to see how just the discussion between the multidisciplinary professionals, how energetic it is, how they validate each other's concerns. So I just wanted to add that.
Well, I am so thankful that you've added that. We have so many unsung heroes in healthcare that really are so dedicated. And Jeanne, we're so grateful to you for giving us a new opportunity, a new way to serve, and you and Mayo for doing that for us. It's just been fantastic. And what I'd like to do, I know we could keep going because there's so many questions that we want to ask, and Jeanne, I know we'll want to ask you back. And but we want to finish on time. We know everybody's got duties, and many have clinical duties. Jennifer, would you please close us? God bless you all. Thank you so much. We'll let Jennifer have the last word, and then if the speakers could stay on just for a couple minutes afterwards so we can do our own process improvement loop on how we can help the speakers. So go ahead, Jenny. Please close it, and thank you to everyone.
Oh, thank you, everyone, so much for being here. And I just wanted to comment, I'm very grateful for these patient and family committees, the PFACs, and especially with regard to safety and quality. I think that the key to the future is using the patient and family, as one of my colleagues has been talking about for many years, adding patients and families to root cause analysis. And, of course, using great discretion in doing so. But I'm hoping someday one of your hospitals might do that pilot project and start the ball rolling with that. But, again, I can't thank you enough and urge everyone here to share all of this wonderful information that will inevitably save so many lives in the future. And I just wanted you to know how grateful I am, Dr. Huddleston, for what you're doing with regard to talking to the physicians and taking them out of one mind frame and mindset and putting them into, is this how you would handle this with your family member? Because we've found that in the patient advocate community that is a really very strong deterrent to, potential medical accidents when things like that do occur. So I just want to applaud you and thank you so much, and I hope that idea spreads to every hospital who's listening today. Many blessings to all of you, and thank you so much for being here. Thank you, Dr. Denham. I'll turn it back over to you.
Thank you, and we'll look forward to seeing you all in November.